They say every life transition is a bridge between who you were and who you're becoming. In many cultures, topics like menopause are often whispered about, if mentioned at all. Yet, this is a natural phase that affects every woman on the planet, bringing with it a plethora of physical, emotional, and psychological change. Today, we're breaking the silence. Joining me is Dr. Sarah Sharif, a well-respected family medicine specialist here at Genesis Healthcare Dubai. And she's with me to explore the realities of menopause, perimenopause, and postmenopause. And we'll be discussing support systems, debunking myths, and what to expect. So whether you're approaching this stage in the midst of it or supporting somebody who is, then this conversation is for you. Let's get into it. Dr. Sarah, thank you so much for being here. Thank you and welcome to They Say It Takes a Village.
Thank you very much for having me. It's very exciting to be here.
Honestly, I feel like I'm so grateful because I think we talked a lot about today's topic and what we are wanting sort of to get out of today's interview and just the information that we want to put out and just to understand the fact that, like we talked about, this happens to every single woman on the planet. So you being here and taking the time out, I'm super grateful for it. And it's just, I think it's definitely to have more conversations like this is not just needed, it is imperative that we do. So thank you so much.
Totally agree. Thank you again for having me.
Just for, in terms of who you are, what you do, what gets you up in the morning, do you want to give us a little bit of a background?
So my name is Dr. Sarah Sharif. I'm currently working in family medicine in Genesis Healthcare, but a few years ago decided to specialise in women's health. I suppose I trained in Ireland and then moved back to UAE and worked initially in family medicine, but then made that transition to breast care and women's health and really haven't looked back since. And then probably around COVID, really, I think, it just was that change, wasn't it? And it gave you that opportunity to look at things. I was seeing an awful lot of patients who were going through breast cancer or coming to me for, regular breast checks, a lot of women in women's health. And a lot of them were going through menopause and perimenopause. And, I realized I really didn't know a huge amount about this. And I really felt I wasn't able to help these women. So really, I think around COVID, that was really the catalyst for me to go back to training and really immerse myself in this topic. And really, I haven't looked back. So now I find most of my days actually spent seeing perimenopausal patients, and I really enjoy it because I feel like it's an area that we really need to concentrate on, So women's health is grossly underfunded, I feel. And I think what's exciting now is that we're beginning to realize this, and a lot more studies are coming through, and there's a lot more exciting things on the horizon. So yeah, it's a really, really good area to be in.
Absolutely. Honestly, the work that you do, it is, like you said, it's crucial and it has to be done. And obviously to jump straight in, because you focus so much on women's health, for everybody who's listening, to be honest, even for me, if you want to sort of just at the heart of it, how would you define postmenopause or perimenopause, menopause, and postmenopause? I mean, what are the clear distinctions between the two? Because I only say that, I think we were just talking, I don't actually know. I didn't really hear about perimenopause till about a year and a half ago, something like that. I didn't even know that existed. I mean, I think everyone's heard of menopause and, roughly what to expect and things like that. But then it goes beyond that, doesn't it?
Yeah, there's so much more. And I think it's so true what you've said. We just thought of menopause as that was it, that we couldn't have babies anymore. And, women that was it, we were old. But of course, it's not that at all. And there's so much more to it. So I suppose if we start with definitions, perimenopause is that pre-stage to menopause. And perimenopause can go on for several years. And what actually happens is that usually about the average age of 40, we have about 3 to 5% of our eggs left. So our eggs are declining. And of course, it's the cells around the eggs that produce the hormones. 3 to 5%. So, and of course, this is different for everyone. This is just an average figure. So that means that our ability to produce the same levels of hormones are also declining. And, through perimenopause, there's this continued slow decline of that ovarian function until we reach what is menopause, where we haven't had a period for a full year.
Okay.
So perimenopause can go on for several years, and it can vary from being months to 4 years to 7 years to actually 10 years. And a lot of women will actually be in perimenopause and not even realize until they start to get the more extreme symptoms, which are usually about maybe 2 to 3 years, sometimes 5 years before that time when the period stops. Menopause is defined as that day in time when you haven't had a period for a full year. And then everything after that is postmenopause. But what we're realizing is actually that there's a lot more to menopause than just our period stopping, and that the symptoms can actually start several years before. And actually, it's much more important to get in there early and start managing those symptoms before that actual day of menopause.
Okay, so for everyone who's listening, including myself, in terms of a woman's life and age, where are we looking at in terms of an age range for menopause?
So the average age of menopause is anything from 45 to 55.
Okay.
Right? In Northern Europe and America, it's about 50, 51. In the Middle East and Asia, it's actually 48.
Oh, wow.
So it really varies. And of course, because perimenopause is so different for everyone, it's really that time, as I said, when the ovary starts to decline. And what happens is that the brain picks up on that and starts to repeatedly stimulate the ovary. So what you get is these big fluctuations in hormones. And that really is what characterizes perimenopause. We can be up one day and suddenly we're really low the next day. And, and that seems to increase until we finally get to that point where our period stops. But because of these fluctuations, it's really difficult to do any kind of blood test, urine test, saliva test. And so we don't really have the ability as of yet to do a test that will tell us exactly where we are in that journey. So the only guideline we have is really our mother's age of menopause. And of course, 50% of our genes come from our father. So,
Gosh, it's not very reliable,
no,
is it?
it's not. So really, I think, what I say to women is, when you're starting to experience those symptoms, and this is where education comes in, when we know that, okay, this is just more than my child being sick at night and I'm really tired, or, I've had a really stressful week at work, or, basically I'm just under pressure because school, work, parents, teens, who knows, when all those symptoms start to come together, especially if we're in our 40s, then we really have to think, okay, this could be perimenopause. I have women who come to me from anything from 35 to 58. So it really, really does vary.
A range.
Yeah. But anything under 45 is considered an early menopause. Anything under 40 we call premature ovarian insufficiency. And we're a little bit more aggressive with treatment of those women because they're going to be without their hormones for longer.
I see. Okay. So you are, okay, let's break it down even further. Now let's talk about the hormones.
Yeah.
What hormones are we talking about specifically? I think we all know the estrogen and the progesterone. Are they the major
Yeah,
players?
so we have three main hormones that we talk about, really. Estrogen, which I like to think of as our CEO, if you like. And there's actually three different types of estrogen, but it's estradiol that we really talk about. Then there's also progesterone, a really, really important hormone as well. And then also testosterone.
Oh, yeah.
So we have these three hormones. And often the first hormone to decline is the progesterone. So an early sign of perimenopause could be basically a change in our period. Our period might get heavier and longer, might get shorter and lighter. Maybe we skip a month, maybe we get 2 in 1 month. Another sign of that declining progesterone might be that we get worsening PMS, especially for somebody that has had PMS all our lives. That can actually worsen in perimenopause. And sometimes we even feel that we have PMS now all the time, so it's not really PMS, anymore.
God, I feel like you're just explaining myself currently.
But again, what I say to women is that we're all different. And I think that's the really important thing about perimenopause and menopause care, is that we are all individuals. No two women are alike. So, when we manage these things and we advise patients about them, we really have to look at it holistically. We really have to tailor that to the individual patient.
That's right.
So the third female hormone then basically is testosterone. And even though that's primarily a male hormone, actually we have it. And, when our testosterone levels are low, it can really affect some women. And, low libido is often a symptom that's associated with low testosterone, but actually it can affect our concentration, our motivation. We can have huge fatigue with it, joint pain. even, so lots of symptoms can be tied to these hormones.
And just so I understand, so basically, as you approach, let's say 51,
Hmm.
this is a steady decline of all three hormones.
Yeah. So basic, and of course, there's going to be, peaks and troughs of each,
Okay. And this
and
is as your body's kind of regulating and adjusting.
exactly. I think to look at it, we go through these transitions. Women are pretty amazing, actually. I
I was
mean,
just going to say,
yeah,
I mean, if you think of again, I'm always going to bring it back to a man, but if you think about a man's life, you've really the most, I guess, evident hormonal shift is during adolescence to adulthood, I assume.
yeah, exactly.
Whereas women, it's just that up, down, pregnancy, childbirth, well, all the, and then menopause.
Yeah. So I think it's our third transition, if you like. I mean, if anyone's interested in books, you should really check out, the work that's been done by Dr. Lisa Mosconi. It's absolutely fascinating. And she has done a huge amount of work on the menopause brain. But, the way she explains it is that, puberty, pregnancy, perimenopause, menopause, our brain is undergoing a complete rewiring, if you like. And, the body is adapting to this new phase now where we're going to have a low estrogen. And we do come through the other side. We are happier, we are more content, but it's really this transition that I think needs management because, we put an awful lot of work into supporting puberty, education about puberty. We have an awful lot of help and support structures available for pregnancy, but not so for perimenopause and menopause. And it is a really important transition as well.
Absolutely. And that was the thing. And I think all of us have, talked about or heard about whether it's our mothers that have gone through menopause and they were slightly irritable. And then you hear, of the hot flashes and, that type of phase. And, but to be fair, again, I've got a husband. If I was to ask him, do you remember when your mother was going through menopause? He wouldn't have a clue.
No.
There isn't this open dialogue for I guess whether they're your partner, your husband, your brothers, mothers, father, this type of conversation. And I think the reason of the lack of support because it's almost just like, okay, well, it is what it is. Like this just comes with being a woman. I'm just going to have to get through this stage as opposed to being supported through this stage. And that's where do you think sort of the pendulum is shifting to bringing a little bit more support and a bit more awareness. I think,
Yeah, I think the narrative is really changing, and I think it's about time, really, because what we're realizing now is that there is so much that we can do in perimenopause. So there are multiple symptoms, obviously, that are associated with perimenopause and menopause, and they call them the short-term symptoms. But I personally don't feel there's anything short-term about them because you have them for about 10 years.
I mean, like what, for example?
So I kind of usually say if I start at the head and work my way down, but
Yeah.
again, every woman is different. And what I always say to my patients, look, I'm saying all of these symptoms not to depress you, but to really so that you can make that connection because you may not get any of them, but at least what could be linked. So, I often find it's the psychological symptoms that come first and then the more physical symptoms that come later. But again, we're all different. Some women will never get the classical hot flashes. So some women might notice that their hair is starting to become thinner, maybe drier, their skin is drier, they might get itchy skin, maybe basically they've got drier eyes, their nails are starting to change. Basically, we might develop things like rosacea or pigmentation. Then we might find that we're getting a little bit more anxious about things. Maybe things are starting to overwhelm us that wouldn't have bothered us before. That our coping skills and maybe our multitasking skills are not quite the same they were before. We might notice that our concentration is a little bit affected, maybe our focus, maybe our motivation, maybe we're feeling quite tired. We might notice that our sleep is becoming disturbed. We often get to sleep okay, but we might have multiple awakenings during the night. We might find that our temperature regulation is changing and not necessarily just hot. We might also be cold when everybody else in the room is
Seems
actually
to
the
be
opposite.
fine.
Yeah. So we might find then that maybe our mood is a bit lower. We might have days that, we're quite almost depressed and we're not really sure why.
This is another thing in terms of you do hear a lot about anxiety and depression and things like brain fog and as you mentioned, but a lot of the times again from somebody who's let's say online or what you hear and see on social media and things like that, you often almost associate it with that phase of life being very busy. It is a busy time. I guess I'm not really talking about, menopause at 50. It's the perimenopause. As women are having children later on in life, you're probably looking at a 40-year-old woman with potentially quite young kids. And all the things that you have mentioned just sounds like a really busy day. So,
Yeah, and this is it. And you see, and women are givers, aren't we? So we really kind of, blame it on everything else except
mm,
perimenopause.
mm,
But the thing is, when you kind of break it down, we were busy in our 20s, we were busy in our
that's
30s.
right.
Why is it now that, we're suddenly worried about driving? Why is it now that a school meeting or maybe a podcast like
Yeah.
today is suddenly a really big deal,
And it's
you
just, it's
know?
overwhelming. Yeah.
Mm.
And almost like you just don't want to do it.
Yeah.
Yeah.
And the thing is, the statistics, don't lie. This is the time when there's the greatest, basically, marital breakdown,
Yeah.
when women will leave employment, when mental health, basically, figures are at their highest, So I don't think that's coincidence.
No.
So I feel like, we need to start maybe being a little bit more kind to ourselves. I think we need to start maybe sitting back and saying, okay, hold on a second now, what's happening here? And then once we, kind of look into that, we can actually start to manage things so that we don't get to the point where some patients come into me and they're just at rock bottom.
We'll get to the management in a minute, but I
Mm.
just wanted to ask you, in terms of your opinion, from what you've seen so far from your practice and seeing your patients, what do you think is so severely understood about this phase of a woman's life?
So what's severely understood?
Misunderstood.
Misunderstood. Okay. So I feel like women, when they come to me, sometimes they feel like, well, that's it. I'm old now,
Yeah.
and my
It's the
life is
age.
over.
It's the age
It's
thing.
an age thing. But remember, you can go into perimenopause at 35.
Yeah.
You can go into perimenopause at 58. So I think that narrative has to change. It is not just all about puberty and having babies. Women basically are huge supports to community. I would say that we're one of the main supports to our communities. In olden days, men were often killed at young ages in hunting accidents. So it was the women actually that supported the community. And, we're the ones that pass on that education. The only other, species in the animal kingdom that does that is the whale, and I think it's just a new transition. And I feel like we have to change that outlook to it, that actually it can be a really positive thing.
Mm.
It's a time where I feel women start to come into their own. And, we still have responsibilities. My goodness, teenagers are a challenge. But, we now are free, I suppose, from that regular period, but also, that, reproductive phase. Most women don't want to have babies in their 50s and 60s.
No, they do not.
So, I think we should embrace it, because it can actually be a time when we can actually do so much. But yet I feel society is very much stuck in the younger women and, our ability to have children. But I think that's changing now, which I think is really good.
Absolutely. I think, again, it's more, there is an event that is going to almost come to an end. I think that finality, you've been, sort of in and getting your period since, let's say, on average about 13. So it is there is this almost cutoff. And I think that is the psychological, a bit jarring right at the start, because you think, now I'm in another, I guess, phase in life. And because there's an event that happened at that point, that, again, I'm only talking for myself, I feel that is probably where I would be a bit, I don't even know what to call it. I would probably it would be something that I would need to kind of sit with for a little bit and just kind of figure how I feel out, what it is that I want to do now, that type of thing. And I think if the event wasn't there, you kind of just do go through life. But you're right in the sense that nobody really wants to be having children at 60.
Well, this is it. And I think that's exactly the key, that if we know about it, if we're educated about this, say, for example, in schools, if we talk openly about this within our families and friends, the body is quite clever. Fortunately, not many people wake up and are in full-blown menopause.
Yeah.
Most of us have like that
a period of adjustment.
that 7 to 10 years where we're actually realizing that our body is changing. And that's the really important time that we can get in there and start to do things. And of course, prevent long-term risks as well.
So if I were to ask you, for example, in a perfect world, in a perfect society, and if you had a magic wand, in terms of support, what would that look like to you?
I think we should educate in schools.
Yeah.
I think.
Do they not?
No.
It's only about period and
really,
puberty, isn't
exactly. I mean, I think there's a tiny bit, but not very much.
No, to be honest, I didn't.
No, I don't think we even were, we didn't even get this training in medical school until recently. So I feel like that's the key. Education. I think it should be a celebration. I think it is a really unique opportunity for women to actually sit back and go, right, okay, I've given myself to, basically education, career, babies, right? I need to make sure now, because I want to enjoy this. I want to be around here for another 30, 40, 50 years. And I want to be healthy and happy and strong, Again, there's too much emphasis on skinny and, basically, aging. What I think we need to move the emphasis is to longevity and being healthy and, enjoying the life that we've created. So I think, in an ideal world, I would love more studies in women's health. I would love, that evidence so that I could give very clear and concise answers to my patients. And I would love for my daughters to go into pregnancy, but then also perimenopause without all the fear that's kind of present at the moment.
That's right. The anxiety around it. This is the thing. It's the more you talk about it, the more you educate. And I'm a bit shocked it's true. I mean, we never learned it in school. We never talked about. I didn't really talk about it throughout my adulthood, up until now. Only because, obviously, to be honest, the podcast has kind of pushed me to ask these questions and want to be able to know more, because this is potentially a stage that I'm going through. But if I wasn't, even if I was 10 years younger, this is a topic that would never come up.
And I think our poor mothers, it was just denied, really, and I feel like, if anything, it was, that was the time with all the women's health study and all of those studies that came out that really were very much against, managing menopause and hormonal therapy, etc.
Right,
so I feel like, we are in a much better position than our mothers and grandmothers.
Because there are options.
There's lots of options.
We're going to definitely get through that. But I just wanted to, obviously, you always read about things like, bone health or cardiovascular health or whatever it might be that is potentially linked to the hormonal fluctuations in menopause. I mean, are there inherent health risks when a woman, I guess, goes into that stage?
Yeah, I mean, there really is, because, estrogen, progesterone, testosterone, there are hormones. So, the systems in the body that depend on them, will start to suffer once these hormones decline. And the body will adapt to it. But, that adaptation is not always perfect. And if we have certain genetic tendencies, then we're going to be vulnerable to those changes. So we know that estrogen has such a huge role in the body and really maintains, that anti-inflammatory effect and protects our vessels, our heart. So it keeps our cholesterol levels low, our sugar levels low, our vitamin D levels high, and it protects us from cardiovascular disease. And this is one of the biggest risks, because if you ask me, what's the number one thing that women die from over 50? It's a heart attack.
Is it?
It is. So that's where we really need to be focusing. The other thing, of course, that estrogen is really important is in bone health, so we know that osteoarthritis, osteoporosis, all of this increases. And again, the number of women who die from a hip fracture a year after a hip fracture, is actually comparable to the number of women who die from breast cancer.
Oh my gosh,
so
I didn't know that.
And the morbidity and suffering that it causes. So really, again, we want to prevent all that. And even colon cancer, the risk increases post-menopause. So we know that there is long-term risks, but we can prevent them. So again, I feel like this is a really, really good opportunity for women to sit back and go, right, okay, what are my risks? What are my numbers? Am I getting my regular screens? How can I prevent this? So,
well, then let's talk about prevention.
Yeah.
I mean, I think we can go two camps. So obviously there's the prevention of hormone replacement therapy and then there's potential lifestyle, or can you just do a combination of both? Where does one start?
So I think with the management of menopause, I always liken it to a big jigsaw. You know, not one thing is going to complete that picture. So really, we have to be holistic when we manage menopause. Menopause is not a disease, it's a transition.
Yeah.
So
Just
we
like
need to,
pregnancy is not an
yeah,
illness.
exactly.
Yeah.
So we need to support it in the same way. So while menopausal hormonal therapy is fantastic and a really, really good option for some women, it's not an option for every woman. And really, it won't work unless we're doing all the other things. So I really, when I see a patient, I really start with talking about diet, our exercise. These are huge things. And we know that women who have better lifestyles have much better transitions through perimenopause and menopause, and that their symptoms tend to be less severe. And also, of course, they're preventing those long-term risks. So really, with regards to nutrition, what we want is we want to start nourishing ourselves. This isn't a time to go on fad diets and, restrictive eating, or, basically also kind of increase things like carbs and sugar, because of course, we feel like that, don't we? Our mood is low, our insulin resistance is rising.
You want the quick.
Exactly. Weight gain is a very, very common symptom of perimenopause because our metabolism is changing. We're losing that hormone. So, we are prone to insulin resistance, which means we have sugar cravings, we're tired, we're irritable. Even if we don't eat more, that weight can just climb up. So what we want is we really want to sit back and say, right, I need a diet that is going to love me back. I want a nourishing diet that has lots of good fats in it, that has basically lots of fruit and veg. We're aiming for that 30 plants per week. We want high protein, but again, good sources, more probably fish and plant sources. And we want low GI, so that's low glycemic index. And of course, in that diet, we don't want any processed or ultra processed foods. So really, it's the Mediterranean diet, but low GI. And that seems to suit women, in all of us really, but really suits women in perimenopause and menopause. And then we want exercise. We want to be healthy and happy. We don't want to be in wheelchairs and walking sticks when we're older.
Absolutely.
So again, this is the strength basically aspect that I really focus on. And the types of exercise that we talk about is really the number one thing that I say to women. Look, if you're doing nothing else, please start strength training. And that's really would be 2 to 3 sessions a week, upper body, lower body, full body core, where we're really basically we're lifting weights and we're building muscle, because that muscle is, first of all, it's going to improve our metabolism, it's going to lower that insulin resistance, but it's also going to support our bones, our joints. So strength training is super important. I also love some flexibility or resistance training in there, Pilates or yoga, whichever you like. We want to build that core. And we do need some cardio in there as well. We want to build that cardiorespiratory, but we don't want these big long HIIT classes, where we go every minute on the minute, because we're exhausted. Our cortisol's through the roof. We don't need that. Our cortisol's already high. So what we want is we want short bursts, maybe basically, but then, long recoveries. So, there's a very good lady at the moment, basically. She's doing so much work basically in women's health, and her name is Stacey Sims, and she really, really advocates for that 30 seconds on, 2 to 3 minutes recovery. But again, there's a lot of information out there. So really it's kind of a little bit of everything, And I think a great statistic is women who exercise 5 times a week can reduce their dementia risk by 30%. There is no medicine on the market that can do that.
That's a massive statistic.
It is. And, another thing really is that actually we can get 50% of the way to managing our menopausal symptoms with just exercise and diet and supplements if we need them, and managing our mental health. So, hormonal therapy, of course, it's really important and it's a great option. But 50% of the way is actually through lifestyle.
That's incredible.
It is. The statistics are unbelievable.
So, okay, let's say we're looking at somebody who's in their 40s.
Yeah.
What is the recommendation? I'm not saying that all of a sudden you're going to hit 50 and then, you've noticed that you are potentially, winding up in terms of you can feel or see some of the symptoms that are pointing all signs to menopause. But is it one of those things that you should start implementing or making lifestyle choices well in advance? I think everybody should be leading a healthy lifestyle, but let's say you're not, very comfortable at the gym, or you don't really work out all that much, or, you're trying to sort of cut down the processed food or lose a little bit of weight. Should this be done, let's say, in your 40s, in your 30s, when you're 50? when should you really be buckling down on your lifestyle choices?
I think it's a tricky one. I suppose as a doctor, I would say all the time,
All the time,
because
yeah,
I feel like, health is wealth, isn't it? So
for sure.
basically, if we have that good diet and we're, and we need to be active, whether we're like, 10, 13, 33, 53. But I think basically in perimenopause, it becomes even more important
Mm.
because, when we're before that stage in our 20s and 30s, say, we have what we call a bucket of estrogen in there, and she is doing everything for us. But once that starts to decline, this is why we see the cholesterol levels go up, the vitamin D levels go down. We have to start doing it for ourselves. So it becomes even more important. So I don't think there's a cutoff. I think really, no matter what you're doing, I think, have that as your baseline. So for example, if you only have 5 plants per week, let's make it 10,
Okay.
right? If you are only exercising once a week, let's make it twice a week.
Mm.
Small changes can make massive differences to your health. And then if you're starting to have symptoms in perimenopause, then of course it's really important to start putting these changes in because you'll feel better. I mean, that's the thing. It's not even about the long-term health. Of course, that's a huge thing, but actually you will feel better
Absolutely.
because, we do have these changes happening.
Mm.
So, when you're 20, you might go, I don't know, on an all-nighter for an exam or something and be fine the next day. Not so when you're, 45.
Oh, definitely
So we know
not.
that we need to protect really important things like sleep because that's when we recharge. That's when we reset our emotions. So, that we need to be much more protective of these kind of things.
Absolutely. The only reason why I ask, I feel, again, I'm only going to talk about myself. I've been quite active throughout my life. Um, the majority of it was I've been running since university, but it's only been this year that I've really put my head down and decided to really invest in weight training. And it was only after I think I heard something or read something that 40 is a really good time to start, if you haven't sort of done any type of weight training before. And I didn't, to be honest. I did a lot of running, maybe Pilates here and there, but not actually lifting weights and adding that load. And I've only just started, and I'll be 40 in July. And I hope I didn't, I don't know, do myself a disservice, or I've started too late, or I'm just kind of at the right time, and I'm not going to stop. Obviously, I feel like now this is going to carry on for the rest of my life, but I just hope I did it at the right time.
I don't think it's ever too late,
Yeah.
because again, the body has amazing restorative properties. And I feel like, no matter when you start, you're going to have benefits.
That's it. Yeah.
It wasn't too long ago that actually women lifting weights was unheard of, So, but now it's a real buzzword, and
100%.
thankfully so, because they've realized how beneficial it is for women and how important it is for women to be doing that. Because again, remember, all the studies were done on men. So all these classes and circuits and everything that we know about exercise and physiology, it's all on men because women are very difficult to study. We're not the same throughout the month. So again, we're starting to find out a lot more. And I feel like, I wonder with my daughters, will they be much more intuitive to their cycle, And it doesn't mean at any point that they won't be able to do anything because of their cycle, but maybe they might be more intuitive and, match things a little bit better than we did.
Yeah.
And we're moving away from this just get on with it kind of,
This is it.
Mantra.
Yeah. Just get on with it. Just get on with it is a phase or a phrase that has literally, I feel, followed women throughout their lives.
Absolutely.
Just get on with it. You've had a baby. Just get on with it. Pelvic floor. Just get on with it. Whatever it might be, any phase and stage in a woman's life. It's just, this is just part and parcel. And that's, I think, more and more people are like, no, to be honest, no, I don't want to. There needs to be some sort of recourse from that, and I feel a certain way, and I'm not just going to just sweep it under the rug. And I think that is a really good thing.
Yeah, no, it's really good. And I think, just like you said, even with the pelvic floor, now we have women's health physiotherapists.
Absolutely.
We're much more aware now that actually we can, if we do certain things post-pregnancy, that we can actually prevent maybe incontinence later in life.
Yep.
So, I think it's all knowledge and education, and that's never a bad thing.
Yeah. It's just so funny when you were talking about all the studies have done on men. And it's things like, for example, when you talk about nutrition and health and dieting and all that kind of, these types of things when it comes to what you're eating and how you're eating. It's true. I assume all of them are studies on men. Things like intermittent fasting, um, high fat sort of keto diets, and things like that. Now, where do you see these types of patterns of eating? I mean, is there, aside from the Mediterranean diet, should we be, I don't know, if somebody wants to do an intermittent fast, is this something that is recommended, or you're going to have to look at it as an individual? Or, I mean, how does it
I
work?
think, yeah, exactly. I think we have to look at it as an individual, because there's so much conflicting information out there. On one hand, people say that intermittent fasting is really a positive thing, but on the other hand, then, it's actually quite a negative thing for women. So
Yeah.
I feel like again, it's that, individualizing care. For some women, intermittent fasting might be something that they've always done, but will it work in perimenopause? Remember, our bodies are changing. Other women will continue to do it, and maybe their bodies are still under that continued stress if they intermittent fast, but look, if it's always worked for them,
That's fine, yeah.
but then I find that actually it almost puts stress on the body. So I think it's nearly better to focus on, well, what's in the diet? Again, am I nourishing myself? Am I getting in my 7 veg and fruit per day? Am I getting in, as I said, 30 plants, that's our aim, but lots of plant-based foods during the week? Am I getting in that protein? Am I doing the low GI? How do I feel? Is my energy level better? And I think that's the key to understanding what's the right diet for us, because we're all different. Some people will be vegan, and that's wonderful, but a vegan is a very high carb diet, and it doesn't suit a lot of women.
That's right.
But some women thrive on it. So
Yeah.
I think it's really more about what I would like to say, what's nourishing us. If we're intermittent fasting and having 2 small meals a day, and we're not getting those things into, we don't have sufficient quantities of those things in our diet, then it probably isn't suiting you. So I feel like it needs to be tailored to us. And, the protein is also another revelation. A lot of women don't have enough protein in their diets. And again, that's really important, isn't it? We're weight training. Otherwise, you're building a tower with no bricks.
That's right. So, okay, let's say, I mean, how does one go about tailoring something like this? Is obviously they would come to see somebody like you. What would you do? Let's say you've got somebody who's coming into your office feeling all sorts of things. I mean, are there blood tests? Is there an ultrasound? I mean, how do you go about figuring out what that woman needs?
I think, what I say to women is, look, choose someone that you feel heard with, that you feel safe with, that you're going to get your questions answered, and probably has specialized in this area, because not all doctors do actually, work in this area. And really, when we meet a patient, we go through what her symptoms are. What are the symptoms that are affecting her? And then basically talking about what her lifestyle is like and what are the improvements that we can make there. If she's under 45, then we will do a hormonal blood test. But if you're over 45, really the guidelines say not to, because you probably are in perimenopause, and what's much more important is maybe to do blood tests for your sugar or cholesterol, your thyroid, which can also cause similar symptoms, your full blood count, your iron, your D, your B12. Because what a doctor wants to do is to make sure that we're not missing anything else. These symptoms are non-specific, and, they could maybe be the cause of something else. So really we want to, investigate that. What's the woman's past history like? What's her family history like? What are her risks? And then really this is a really unique opportunity to, of course, refer that patient for a breast check if she hasn't had one, for a pelvic check, a pap smear. So these are all really important things to do in that consultation. And then from there, we would tailor the management really based on the results of the investigations, and that might be in the form of supplements. Maybe if she has deficiencies, some supplements will also support some menopausal symptoms earlier on. And if that wasn't enough, and basically for some women, if they have more severe symptoms, it may be menopausal hormone therapy.
And what is that?
So menopause hormonal therapy basically is where we replace, those lost hormones. So we're giving back a little bit of estrogen, progesterone, and for some women, testosterone. Okay. And these are low dose. They're not going to prevent a pregnancy. So a woman in perimenopause will still need contraception, if she chooses to. But what they are is they just rise that level a little bit so that the woman doesn't feel those symptoms so intently. So the benefits of hormonal therapy is that it can reduce your cardiovascular risk by 1/3. It reduces your risk of osteoporosis and prevents osteoporosis, and is also a treatment for osteoporosis. And it's also the best thing for treating any anxiety or depression that's linked to menopause. And it helps a lot of these short-term symptoms. So, basically, for example, the commonest one is hot flashes. The side effects from them basically are usually pretty minimal. The biggest one is irregular bleeding. Right? That's the main thing that women come back to me with. But to be honest, sometimes by the time they see me, they have irregular bleeding anyway. Sometimes bloating, sometimes nausea, sometimes breast pain. But generally, we start very low and we go very slow. So usually side effects are avoided.
And then you sort of work out what's the right dose for each person.
Yeah, exactly. So then I suppose, we can't mention benefits without mentioning risks. So what are the risks? And I think this has been a real, turning point in history because, of course, throughout history, hormonal therapy has been vilified, really.
It's quite controversial.
Yeah, it is, So I suppose the first thing that we say is to women is I always like to get a baseline pelvic check because, again, this is a time of great change and we can develop things like fibroids or cysts or, polyps. And it's always good to have a baseline pelvic check before we add any hormones into the mix. And what's really important is that when we give hormonal therapy that we mimic what's happening in the body. So you will never get estrogen in the body without progesterone because one causes the uterus to thicken, the other one causes the uterus to shed, if you like. That's a simplistic version of it. So when we give estrogen therapy, we must always give progesterone therapy to protect the uterus. If we don't, then there is a risk long term if there's continued more high dose estrogen therapy, but there is a risk of uterine cancer. So we want to prevent that.
Okay.
The second risk that everybody asks me about is, of course, breast cancer.
Yeah.
And that is really the really controversial point. And again, this is why care has to be individualized. It's really important to know about that woman's past history. If she has had a history of, say, atypical cells on the breast, which have been found on biopsy, or she has a history maybe of calcifications or some changes in the breast, then hormonal therapy may not be right for her. If it is a choice that she wants to look at, then it needs to be done, in collaboration with her breast team. Right? So, that really has to be individualized. But if somebody has had a normal mammogram and ultrasound all their lives, then really, the risk is very, very low. And the risk seems to increase after the age of 50. But to put that risk in context, if a woman has a large glass of wine at night or she doesn't exercise, basically these are actually bigger risks than taking hormonal therapy. And actually the biggest risk to breast cancer, which I feel like we should talk about more, is being overweight or obese. So, if we have a large glass of wine at night, basically that can increase our risk by 4 times. Taking hormonal therapy in the study that I'm talking about used synthetic, not the more natural form that we use now. That would increase our risk by 4 times. Okay. Right? But if we basically are overweight or obese when those periods stop, that increases our risk by 24 times. Wow. So, our biggest risks for breast cancer are getting older, being female. We can't do anything about that. But lifestyle. Yeah. So if a woman is really suffering and we do use hormonal therapy, she's probably going to get better sleep at night. So she's not going to need that glass of wine. She's going to feel better. So she's not going to need that glass of wine. She's probably going to make better food choices. She's probably going to exercise more. And that's probably going to lead to a loss of weight. So again, we have to individualize things. In that case, I'm actually reducing risks.
Just so I understand, initially the big, I guess, controversy around, is it the synthetic HRT, is that it had a link to potential breast cancer?
What happened basically in the 2002 study is that what they said was that there was an increased risk with hormonal therapy.
Got you.
But of course, there's been so many, things that have come out since. And really, there's so much information on this in social media now, which is great. And, really, they used high-dose synthetic hormones. And the cohort of patients were much, much older, in their 60s. So, of course, things like cardiovascular risk, and breast cancer risk were already much higher, than, say, a woman in her 40s. So there's lots of discrepancies with that study that
Yep.
really now we understand, have been thrown out really, but what I really welcome now is new studies, because we need more clear guidelines so that we can give women that. I think it's still a really difficult choice for women to make, to go onto hormonal therapy, because it is not so clear,
Yeah.
and
There are a lot
really
of holes, a little
there's a
bit.
lot of
Yeah.
holes,
It's a
but
very strange thing. It's almost quite shocking that there aren't enough research on it.
it really is. And I think the thing is that what a lot of women don't realize is that actually, for example, for women who've had a uterus removed and they take estrogen therapy on its own, that actually has a protective effect against breast cancer. You see, so, I think, again, it's all about that individual. And if you do go on hormonal therapy, it's about having that regular screen and knowing that, actually my risk of cardiovascular disease and osteoporosis is far higher, and that's probably going to affect me first. But maybe if I improve my lifestyle, I can reduce my risk of breast cancer. So I think it's that discussion with the doctor that's really important.
My other question is, you mentioned that there's the synthetic and then the natural.
Yeah. So what we tend to use is more what we call body identical,
Okay.
right? So body identical is made from the yam plant. So it's much more natural. It's identical to what we produce. And this is now what you will get on the NHS. This is basically what's been FDA approved. And we find that basically the estrogen is given in the form of a gel or a patch through the skin. So
Okay.
it doesn't interfere with the clotting processes. So therefore, it actually reduces our cardiovascular risk. Because it is so close to what we produce, it's tolerated far better. And we know that the risk of breast cancer is lower. So there's a lot of evidence coming out in this area. And it's a much better option for women rather than taking the oral synthetics, which are a little bit more similar to the pill, if you like.
Are they even still around?
They are, because for some women, the body identical isn't maybe a choice, and we are a little bit limited, in this part of the world as to what we can access. I feel like, we should have more choice, because we only have one type of patch. We do have the gel, but the stocks basically go in and out. And we have that natural progesterone, which is really good. But I feel like, women should have access to more. There's different type of patches that are very small, for instance, that are much easier to use. There's actually the spray as well. And I think, we only have testosterone that's actually for men. Australia is the only country in the world that has the testosterone that's actually for women.
And why is that? I mean, I'm just trying to understand.
Why indeed?
I just want to understand. I mean, it doesn't make any sense whatsoever.
Because I feel like women's health is just, neglected to a point. It really is. And I feel there's still a lot of fear around hormonal therapy. And it is that just get on with it kind of attitude, which is changing, because I think now women are saying, absolutely, no, we don't have to get on with it. We don't have to be, older and have risks of hip fractures and cardiovascular disease and all the other things that come through it. Yes, that's a normal part of aging to a point, but we can prevent these things.
Absolutely.
And I suppose I've talked a lot about hormonal therapy. I mean, there is other treatments there. For example, there's a group of medications called the SSRIs. They're antidepressants. They would never be my first line. But a lot of women, for example, who have had breast cancer have used these medications and, they can be really successful. But for that small group of women who have had breast cancer and have very severe symptoms, there still is a lot of debate. And, they're the ones that are really suffering because, a lot of clinicians are very fearful to give them hormonal therapy, which rightly so.
Yeah.
So I feel like, again, we need more studies in these areas so that these women don't have to suffer.
Need more study, need more funding.
Yeah,
I mean, if this was
absolutely.
a man's problem, and I hate to always bring it back, but this would not be the case.
I think that's kind of probably multifactorial, and like I said, men are easier to study, aren't
True,
they?
true.
So
Yeah,
I think
it's simpler.
that's probably where it's come from as well. But yeah, absolutely, and I think we're beginning to realize that now. So there's a big push for it.
Yeah. I've got another question just quickly about the HRT and whether they're synthetic or is it bioavailable, you said?
Body identical. Yeah.
Body identical.
Yeah.
Is it one of those things that you take a certain dose and you take that for life, or do you wean it off? Or I mean, how does it work long term?
Again, I feel like I've said this word a lot, but again,
Yeah.
it's quite individual.
Yeah.
So, look, we would really start at a very low dose and we would increase very slowly because we're
Okay.
all different, right? So, and then really based on that woman, we would see what she suits. So, for example, if we were using the gel, we might start with one pump, sometimes even half a pump, for example, if a woman had migraines. And then we would build that up. And most women will probably use maybe about 1 to 2 pumps. Some women will need 3 pumps. Some women will even need 4 pumps because
Of
they
the
don't,
gel.
of the gel, because they don't absorb it. And
Okay.
then we have the matching doses, say, for example, in patch form. So it's really about, getting that dose right so that those symptoms are controlled. And that can take up to 3 months, sometimes even 6 months.
Okay.
And once a woman is on that desired dose or the right dose for that woman, it might still need to be tweaked. But how long she stays on it is really up to her. Some women still have hot flashes in their 70s, so they have chosen to stay on it for life. A lot of women will just take it maybe for 2 years, maybe for 5 years, maybe even for 10 years. I think at some point they will say, right, you know what, I'm going to start to reduce it and
So
see how I
taper it
feel.
off. Yeah.
If they don't have those symptoms anymore, then great. And remember, diet, lifestyle, managing our mental health, this is all supporting us. But I think in order to get into that zone where we can actually change our lifestyle and manage our mental health, sometimes we need a little
A
bit of
little
help.
support.
Yeah.
So it's just really, it's a combination, a little support with active adjustments to lifestyle
Yeah,
and exercise.
absolutely.
And that's hopefully should sort of mitigate discomfort in that stage.
Oh, it absolutely
Yeah.
does.
Oh my God, I still can't get over the fact that things like the availability or different options that are offered to women are limited.
Highly limited. I think, we're quite lucky here actually in the UAE, but
Yeah.
there's so much more that we could access, and I feel like it isn't right, that we have these medicines, that should be available, like any other medicine is available. They are licensed in other countries. Why don't we have them here? So I think, I think it's changing. I think, we can't just say the UAE. Basically, of course, the UK, America, everywhere is undergoing shortages because, they just are not developed enough in this area.
Let's see that change hopefully within the
Yeah.
next, for at least our kids and their, sort of their generation. You touched on it very briefly. You mentioned that at that point, I can't remember the statistic that you mentioned, but sort of marital divorces and I guess in terms of intimacy, sexual health, things like that. These all are, I guess, I don't want to say symptoms, but they all kind of go hand in hand a little bit when it comes to menopause, perimenopause. Is this something, again, due to major fluctuations of the hormones? And is there something that, aside, I mean, I guess just living that lifestyle and potentially that extra support, are we able to sort of get back on track?
I think again, it's, understanding that change. Our hormones are lowering. So that ability to have children is also basically declining. And as I said, most of us don't really want to have that ability in our 50s and
Yeah.
60s. But with that, of course, comes changes. Men don't have that. They lose 1% of their hormones per year. So there is that natural change to, say, our desires. And I feel what happens, which is quite sad really, is that women, pull away because for multiple reasons, they don't have the same feelings that they would have done, but also sometimes they don't feel as attractive. Maybe they're having hot flashes and they're not sleeping,
It's
maybe
just general
exactly.
discomfort. Yeah.
And I think sometimes the partner feels it's them. And of course, it's got very little to do with the partner and everything to do with the woman. So it does. I think it's again, basically, it needs that open conversation. It needs that adaptation. I think if the partner understands, if they can be that dialogue, then, that relationship can be really solid. Maybe it's finding a new interest together that isn't around, babies and work, etc., and family, responsibilities.
Responsibilities.
Exactly. Maybe it's creating that, intimacy and that feeling of safety because, that's far more important to women. And, it's having your partner understand what the changes are. And I think that really can be a really positive thing then.
Do you know what? Do you know when you find out you're pregnant and you and your partner go in to do like a prenatal class. This should be the exact same setup for perimenopause and menopause.
Yeah, actually, I never thought of that. It's true.
I mean, you go into the and you learn all about pregnancy and birth and your different options and what to expect and how to care for the baby or for the newborn. I mean, essentially, it's the same thing, isn't it? At a
I think,
different phase.
yeah, I think basic, and that's why when I see patients, I really encourage women to, I say, look, share these articles
Absolutely.
with your husband,
Yeah.
with your partner, because then there's understanding, isn't there? Then there isn't that feeling of, oh, maybe she doesn't love me anymore, which I think, as I said, is really sad. So I feel like, yeah, again, it comes back to education, to having that dialogue.
Maybe Genesis can do it. Sort of a perimenopause, menopause workshop.
Maybe, yeah, absolutely.
And have it run
great
just like
idea.
a seminar, and it could be over, let's say a 2 or 3 week period. You come and you just understand, because I mean, this could potentially be like couples therapy.
Yeah, yeah. And I think there's a lot more actually, becoming available. We know that cognitive behavioral therapy, for example, can be really useful in perimenopause. And I often refer my patients for that, So again, it's that multifactorial kind of management, isn't it? It's those different arms of management that are really important.
Yeah. No, I totally get that. And I think there is obviously a strain. I mean, you're looking at, let's say, you've been married for a very long time, and, it's not like, you have that same spark as you did when you first gotten to know each other. Then you are getting to the point where, yes, you might feel uncomfortable within your own body. So therefore your intimacy is, your sex life is not really where it used to be. And that, again, people do take it personally. And I think an open conversation about what is potentially happening, I think, is very, very important.
Yeah, and there's therapists for this. There's a lot of support out there, and a lot more information. So, you don't need to be on your own going through this.
Yeah.
I think that's really important.
And I think women have gone through it on their own.
They do. I think what's positive about women, however, is that we do talk to each other.
That's right.
We're much better at communicating, and I think we're much better at that than men. And I think now that we are realizing this, this is the social media storm that we have, because I think women are waking up and saying, oh my goodness, and it's been shared, so I think that's a really positive thing. So I feel like, yeah, I think that we're going to be going into a very, very exciting kind of new age, if you like.
Yeah. If you were to talk to a woman who's your patient and her partner came along with her, what would be the best way for him to support her?
I think just, understanding what perimenopause is, basically read the articles, understand the changes, because I think if you understand, then you can really support.
That's right. Yeah, I think that's it. It's just kind of understand, don't take it personally.
Exactly.
It's not something that you can fix. It's something that you have to understand and really work with your partner potentially.
Yeah, and some partners are great. They come in and they've looked up the hormonal therapy, and they're, they have lots of questions, and so it's great. And then some women, come in and say, no, I haven't said anything to my husband. He just won't understand. So I think, they are, fortunately, we're getting more of the first type, but yeah, it's changing.
It's changing. That's the main thing. And I think if there is conversations like these, like the majority of the work that you do, you have really sort of almost, I feel become a crusader of women's health. And I think that is very important. And it's just, there's nothing worse than feeling like you're the only one out there and you've got the problem and you have to deal with it completely yourself. And I think that's where it becomes quite more than anything else. Yes, the symptoms or potential discomfort is not great, but not being able to understand that there is support that's going to be effective, to understand. I've got friends of mine who are kind of going through that, and it's almost like I was referred from one person to the other, and no one really understood what I was talking about, and it was really frustrating because also who's got the time to go from one opinion to the next without actually listening and understanding. And this could potentially be, or even just as a process of elimination, it could be this, let's do something about that. So it's just to know that there are people like you that are almost quite excited about making sure a woman at, I would assume, all stages of life is comfortable in her own skin.
Yeah, Absolutely. And I think that's just really important. You know, I think we need to get in there early. We need to be supporting women. You know, we need to be preventing these very preventable long-term chronic conditions.
Yeah, I mean, like you said, 50%.
Mm.
Things like that, diet and exercise, exactly how to do it. I mean, you know, as you mentioned, going into a crazy fast hit class may not necessarily work out. Might want to
No.
switch it up. And these are small, minor adjustments that you could potentially do. They're not
Yeah.
sort of night and day life choices. So you could really just be tweaking almost, as opposed to really revolutionizing that person's life, which is good to know. You know, I think we're all quite worried of major life changes, but these incremental little things that you can do daily,
Yeah, makes such a
a
difference.
huge difference.
Yeah, really, really big. And I think that's a lot easier to take on, isn't it? You know, rather than thinking, oh my goodness,
My
I have
God,
to change
yeah,
everything. But actually you don't, you know, like you just need to maybe increase a little bit more veg on your plate, you know, basically maybe, you know, taking a walk, you know, a few more
that's
times
right,
a week,
yeah.
as well as maybe the other exercise, you know, just little things. Maybe it's instead of trying to do 10 things today, I'm going to do 5 things really well.
Absolutely. Maybe
you
it's
know?
just literally even just starting bedtime routine 20 minutes earlier.
This is it,
Yeah.
you know, and so that you can enjoy that. Why am I putting this pressure on myself? You know, because I do feel society does expect women to be, you know, basically, you know, in the workplace, but also a fantastic mom. We're meant to look amazing. We're meant to be seeing loads of exercise. We're meant to have amazing meals and lunch boxes. It is not real life.
No,
you
it's
know?
not. And it's
No.
not, it's never going to be the case.
No.
You know, the idea, I think very much my generation. I don't know what generation, my gen, I don't know even.
Yeah.
Not sure. Definitely not the Gen Zs, but you know, we kind of got sold an image of you can do it all.
Yeah.
And have it all.
Yeah.
You can raise the babies, you can be all about your career and be fully present at your job, yet come home and make sure to, you know, World Book Day costumes are all ready.
Exactly.
And, you know,
and it's nonsense, you know.
and also get in your workout, you know, do what you need to do, make sure you look fantastic, and, you know, social commitments, and, you know, feed your marriage. And
it's exhausting.
I mean,
yeah, and it's exhausting. And the thing is, you know, and I think when we're doing all that, we're actually missing the real things.
absolutely slow down.
Yeah, which is maybe let's sit here today and not do anything.
That's it.
Maybe we'll just go for a walk on the beach.
Absolutely.
You know?
And that is more than enough.
Yeah.
And I think it's that, do you know, I think I'm getting to the point where I can realize, or I can pinpoint where I felt overwhelmed. And I don't think I had been able to do that before. I was like, no, it's fine, I'll do it. No, it's fine, I'll do it. And by the end of it, I'm either snapping at my kids or my husband. Whereas now I can feel, okay, yep, I've pushed a boundary. I can't seem to cope in whatever that task is. So I'm just going to step back a little. It's just not for today. But again, I say that, and that's when I'm really sort of very in tune with how I feel. But it's practice. It's just learning.
Yeah, absolutely. And I think perimenopause almost, you know, it almost forces you to do that, you know, because you kind of go, actually, you know, I'm just not feeling good. You know, why am I so stressed all the time? So I think, you know, realizing that, I think, is really important for women. And I think, you know, protecting that family time, you know, definitely devoting ourselves to whatever career we've chosen, you know, and also basically, you know, exercise, etc. But, you know, doing it within the limits that, okay, if I didn't go for a walk today, I'll go for one tomorrow.
That's right.
You know?
It's not the end of the world. Don't
no,
beat yourself up
exactly,
about it.
you know, and if I don't have the most amazing costume for
World Book Day, Amazon is there.
Absolutely
just order
fine.
it.
This is it,
Yeah.
you know, and it's fine,
Yeah.
you know. So I think we just have to give ourselves a bit of a break.
Yeah, I totally agree.
Yeah.
And for the woman who's listening today, either, you know, sort of, again, going through, is this, you know, maybe am I perimenopausal, in menopause, coming out of menopause? What would be your biggest sort of take home?
I think basically connect. I think educate yourself. I think, you know, find a health professional that will answer those questions, you know, that you can go in, whether it's in your 30s, 40s, 50s, you know, and have that conversation. You know, there's a lot of really, really good resources out there now. And there's some great books out there. And, you know, basically check them out, you know, because the more knowledge you have, then it's power, isn't it? Because then, you know, when you do have some of these symptoms, you'll understand, actually, this is not me. This is my hormones changing, and that's very different, isn't it? So I think, yeah, that's really my message to women.
Just get the information, ask a lot of questions.
Yeah, yeah.
And I think that's what it is. Women tend to prioritize themselves or deprioritize themselves and
Deprioritize themselves,
yeah,
because if we don't fill our cups, we have nothing to give.
no.
So we've got to take a step back, fill our cups, and then we have so much more to give.
I couldn't agree more.
Yeah.
I feel like I can keep you in here for hours. We'll do a part 2, because I wanted to ask you things like, now things on the market, like the Ozempics and the GLP-1s, and they were talking a little bit about that with menopause. And I'm like quite conscious that we keep talking, but we'll definitely have to do another. And I think it's because of this whole insulin resistance, but we'll keep that for another day.
Sounds wonderful.
Yeah.
Sounds wonderful.
Well, obviously, to end the episode, I always start with a quote to kind of just give context on what we will be talking about. But to end it, I always want to ask the guest if they've got a quote or a saying that they kind of live by, or something that kind of, I don't know, that they incorporate into their life and work and all sorts of things.
I think, yeah. So I think that's a lovely thing to end on. So I suppose the quote for me would be, live the life you love the life you live. It's one by Bob Marley, but
I love it.
You've got to love it.
Yeah.
You've got to love your life.
And you've got just the one.
Yeah, we're only on this planet for a short time. So, enjoy it. So that's my quote.
I absolutely love it. Thank you so much. The work that you do is honestly that of a hero, and everything that you've put out into the community and the support that you offer, it's absolutely priceless. And I'm just so grateful for your time and the information. I think everybody who's listening will also truly, truly appreciate it.
It's great. Thank you again for inviting me.
Thank you so much.